Dr. Charles is the owner and medical director of the Center for Sleep and Human Performance. This has a special interest in disorders of sleep, fatigue, and obesity. This session will review the basic science of sleep and the function of sleep for restoration and metabolism. Specific cases of sleep disruption disorders will be presented, and the approach to treatment will be reviewed. There will be time devoted to questions in an effort to address specific concerns that participants may have regarding sleep and training. What I'm going to do is we're going to leave the questions till the end. We'll put the microphone in the middle so everybody can hear the question. So without further ado, Dr. Samuels.
Thanks, guys. You can hear me, eh? So the first thing I want to do is I have to declare my conflicts of interest. I have none. So I've received only support from Swiss to come here with an honorarium and travel expenses, and I have no industry support to be here today. So you can, it's free of any bias, except my own personal bias. I want to start by saying that I have to be honest with you, this is definitely not the best approach. This is a novel approach to the management or prevention of overtraining in athletes over time. So I by no means think that this, or profess to say that this is the best approach. What I want to do in the time that we have, and what's most important, is to address the questions. So I'm going to move through the information and leave a fair bit of time. But we do have an hour and a half, which is quite long. It's to provide you folks, who are a variety of professionals working with various levels of athletes, with a more comprehensive and practical framework for preventing overtraining syndrome. How many of you guys see people who get overtrained in your practice? Yeah, so not everybody. And how many of you think that you could have predicted it? When you see it, you look back through the time and think, geez, I could have seen that coming. Raise your hands. Okay, this is because you guys have day-to-day experience with athletes. So it's very important for you to understand, because I end up working with the Canadian Winter Olympic team medical team at the Calgary facility, and the physicians see the patients when they're sick. So we don't get to see them day to day. So the question is that it really is you guys who are in the trenches seeing them day to day, and what I've learned from working with trainers is that they actually can see these guys getting sick. And so you see things that the physicians don't see and that the biochemical markers don't address. And medicine now is beginning to get it. So what I want to do is, and did last year for anyone who was here, is go over the basic science of sleep, because that's very important. You're hearing a lot of talk about the neuroendocrinology of training and about phases of releases of hormones. And without an understanding of sleep, they're actually being explained inappropriately to you. So I want you to really understand about the neuroendocrinology of the release of various hormones through a circadian cycle. And that's important. That's what we'll talk about a little bit. And then just the science of sleep. We'll talk a little bit about restoration and training. And then I want to talk mostly about training and overtraining, the relationship to sleep, and then give you 3 cases that'll be pretty similar to what you guys see. So the bottom line is I always want to send you home with something to do Monday in your clinics or wherever you work. You have to have something new to take back, and you will. So you'll get a basic understanding of sleep, which allows you an opportunity to now ask relevant and intelligent questions of the people you're seeing about their sleep, not just, do you sleep? Because that doesn't tell you anything. Okay? To provide you guys with the understanding of the neuroendocrinology of sleep and restoration, because I think you hear a lot of stuff, and I don't know that it's actually very accurate, and it's important to have a very good basic understanding and the reality, the truth of what's going on. To give you a new perspective of the prevention and detection and management of overtraining syndrome. So I view this very differently from my sports physiology colleagues who focus on the event. Okay, everything's fine, and then the athlete gets sick. And now we all get all fussed up and start doing blood markers and salivary hormone testing. It's a little bit late. So what we want to do is say, are there ways of looking at athletes from the time they're teenagers to the time they're in their last preparation for their last Olympics, which is what I'm seeing now, is a group of winter athletes going to their last Olympics on their last legs, some of them, okay, in their late 20s. So 10 years out, right? So basically, this is very important because it's very simple, very intuitive. When it comes to sleep, what you need to know with the people that you treat is how much they get and how much they need. This is very important. You got to find out a way of determining whether they have good quality sleep, and that's difficult. And then you have to understand about the circadian timing of their sleep. How many people here are night owls? You love the night, right? Okay. What happens if we ask you to go to bed at 9 o'clock? Doesn't work, does it? No. That's because your brain doesn't want to go to sleep at 9 o'clock. It wants to go to sleep at 1 or 2 in the morning. That's a real night owl. Okay? That's important to know about your athletes, because what happens if you take a night owl and wake them up at 6 in the morning and ask them to train? Anybody? Not a lot. Okay? They don't feel too good. And that has actually been studied, and it's been shown that they can have a very poor response to training effect if you take a night owl, someone who has a preference for night owl sleeping habits, and make them train in the morning. So keep in mind, swimmers train in the morning, and not all swimmers are larks. In other words, people who go to bed early. So that creates problems, and one of my cases is about that. Primary sleep disorders I'm not going to talk about, but I can answer questions if you like at the end. Okay? So the basics of sleep. So the first thing is you have to understand what regulates sleep in the human, and it's very simple. There's a homeostatic process. Bottom line, sleep debt, sleep load. If I restrict you to 4 hours of sleep a night for 5 nights, what happens on the 6th night? Anybody? You crater, right? If you're a good sleeper. If you're an insomniac, you're screwed. Okay? But if you're a good sleeper and we sleep deprive you, you're going to want to sleep. Very simple. That's the homeostatic process. So think about your athletes. When they're sitting on the bus going home, are they all falling asleep at the end of the day? That'll tell you something. They haven't slept enough. Anybody who's falling asleep a lot during the day has a problem. And any athlete who falls asleep in 2 seconds, that's abnormal. And I bet you guys think it's normal. So anybody tells you, oh yeah, doc, I'm a real good sleeper. I fall asleep like that. I go, whoa. Okay? Because normal sleep latency is 15 to 30 minutes. So a well-rested brain takes 20 to 30 minutes to fall asleep. So it's important to understand that, because they might think, oh, I'm a great sleeper, but they're becoming chronically sleep deprived. And that's how you figure that out. The circadian process is whether they're a night owl, a lark, or a middle-of-the-roader, 11 to 7 kind of person. Okay? So it's really important to know that. You'll think that many people are larks because they hop out of bed and go to the gym, but I'll show you a case of someone who did that and almost died from just becoming overtrained. Because it's easy to wake up, put your feet on the floor and go, but that's because you're jumped, not because you're rested. Okay? And anybody who lives around here and has to travel the distance into Toronto getting up at 5 in the morning, they're chronically sleep deprived. The ultradian process is what goes on in the brain. So you've all heard of the stages of sleep, from stage 1 to dream sleep, or REM. They go through cycles, and I'll explain that as we go. How many people here wake up routinely at the same time in the middle of the night? Raise your hands. Okay, usually older folks. Sorry, guys. Okay. So that's very important, because you're going to learn why that happens, because it probably drives you nuts. Eh? You look over at the clock and go, oh my God, it's 2:02 again. Okay? There's a reason that happens, and there are things you can do to mitigate that effect, because it breaks up your sleep. So the homeostatic process regulates the balance between sleep and wake. So we know that the more we keep someone awake, the more they're going to want to sleep. And the fact is, there are certain types of sleep that they will recover first and then later. So there's a lot known about chronic sleep deprivation and acute sleep deprivation through research. It's fun research to do, because you get to torture guys in the military, okay, and athletes. Okay? So the thing is that we learn about what the effects are by sleep depriving people. And Dr. Poliquin mentioned something this morning about the fact that if we restrict sleep, it has an effect on our glucose, our insulin secretion and glucose regulation. And that's true. And that study was done at the University of Chicago in the middle of the 1990s. And it was a beautiful study that looked at normal adults and sleep restricted them to 4 hours a night over 10 days. And what happened is they developed a pre-diabetic state, completely normal, healthy adults. So that's very interesting. And then what they did is they crossed over this study and they kept these people in bed for an additional 4 hours awake. A eucaloric state, no energy expenditure, and their appetite went up. So contrary to what we believe, if you expend energy, your appetite should go up. They were expending no energy and their appetite went up. So we know if we fatigue people, they start eating lots of carbs, okay, and fat. So high-calorie dense foods is the term that we use. And so we know that this is true. We observe it. I work for the Calgary Police Force, and I have a slide presentation, and the title is, Why Do Cops Eat Donuts? And there's a reason. There's a reason. There's science to it, okay? So the need for sleep is determined by the amount and quality of the sleep in the previous sleep period. That's sleep debt, accumulation of sleep debt. Okay, remind me to answer the question, how does coffee work, caffeine work? I won't do that right now, but somebody asked that later. The circadian process regulates the timing of your sleep period. So those of you who are night owls know this, because you have a best time of night to sleep, and you're forcing yourselves to wake up early, because you have to go to work or whatever, you got kids. So you're working against your biological clock. And this is where I see the theme of the long-term theme of the development of overtraining syndrome in elite athletes is if you go back to when they're in junior high school and 17, somewhere in the sort of 11 to 17 period, they all of a sudden develop a delay in their sleep phase that becomes quite entrenched. They're going to bed later, they're waking up at the same time for school, and they become chronically, excessively sleep deprived. Now, there are very fit people who can tolerate that sleep deprivation over a period of 8, 10 years, but eventually it catches up with them. And what you see is repeated injuries and inability to recover over time. As they get a little bit older, they have less ability to recover, and that's the key. Okay? So this is controlled by the exposure of the eyes to light in the morning. Okay, the light sets the biological clock. So your biological clock's in the center of your brain, and it is set by exposure to light, which we don't get in Canada in the winter months. So it's very important to understand that there's a way to anchor the sleep period and adjust it back and forth. So we use light therapy to move the sleep phase around in the athletes, and I'll show you some examples of that so that we can take a night owl and make them a lark, and then they can wake up at 6 or 7 more efficiently, more alert, ready to go. So let me ask the night owls, raise your hands again. Okay, do you eat breakfast? There you go. That's bad. You're a bad person. No, I'm just teasing. So yeah, I'm glad you answered, because a lot of you guys will say yes, because you force yourselves to eat. Now the key thing is, it doesn't feel good to eat, does it? No. So you have to understand, their gut's not awake. So there is a circadian rhythmicity to the gut, and it's not awake. So if I have shift workers who are eating a steak sandwich at 2 in the morning, they don't feel very good. But they're really hungry. So they end up getting the top symptom in shift workers, headache, and heartburn. Top symptom. Okay? There's a reason. So the point is, it's very important to look also at nutrition, because these things are linked. And then there's winter depression that is linked to these people who are night owls as well. So you have to watch that, because in overtraining, one of the top symptoms is low mood and irritability that's related to the development of a depressive illness. Okay? So I hope what I've said here is that sleep and wake are very linked. It's very important to understand that what goes on during now, waking, affects what goes on in your sleep at night. It's very important to understand that. So training is critical. So this is just a picture to give you the idea that the light is transmitted through the eye to the retina, and it's the retinohypothalamic tract that goes to the SCN, and it sets the SCN's timing of your circadian rhythm. Now some people endogenously, internally, set much better than others. Night owls have a hard time setting, and they tend to like very erratic sleeping schedules. Like they just sort of go with the flow. That's not good for an athlete. That's really bad. The brain likes regularity, and that's the problem. And so you can set it by doing this. That's why, now again, I'm not industry sponsored, but the Lightbook people are here because of the work we're doing with the Olympic athletes and the amount that we use that tool. We use it a lot. And we have 25 lights for the Canadian Olympic speed skating team. And they just pack them up when they head to Asia and Europe. And then I communicate with them via email to adjust their timing of light exposure while they're away and during travel. And for some, it works quite effectively to mitigate the effects of jet lag. So all I want to show you in this slide, because this understanding of the phase response curve and circadian rhythm disorders is a bit complicated, but the bottom line is what you need to understand is that your circadian rhythm is regulated by the excretion of melatonin from the pineal gland, and it peaks in the middle of your sleep period. So whatever your sleep period is, melatonin should be peaking at that time. And you all know about salivary hormone testing. And we can, in a research setting, we can determine what's called the dim light melatonin onset, which is a few hours before the peak, by doing serial salivary testing every half hour through the evening. And once we see it start to rise, that's when you would dose melatonin, if you were using melatonin as a therapeutic agent. How many here have tried melatonin? Yeah. And the thing is, how many have sort of thought, whatever? Raise your hands, yeah. Because you have to time it right. The problem with melatonin is that you can't just take it. It has to be timed, and the timing's individual, so it's a very difficult drug to use clinically and therapeutically to get an effect. Okay, it's not like a sedative, which works. So the key thing in this slide is that you need to understand that the temperature minimum corresponds to the peak of melatonin secretion. So how many of you have stayed up for 24 hours? Raise your hands. Of all of you, how many got really cold in the middle of the night? Raise your hands. Okay, you're supposed to. Even if you're like running, let's say you were doing a 24-hour marathon or something, your body temperature is supposed to be cold. Shift workers will tell you that they get really cold in the middle of the night. And that's normal because you're supposed to be sleeping, right? Okay? So the key thing you have to understand is that's another way of determining your circadian phase, is doing a 24-hour temperature monitoring, but it ain't fun because the probe goes up your butt. Okay? So we have new technology that we can use where you can swallow a capsule and we can monitor your core body temperature very accurately through telemetry by just swallowing a capsule. So that's kind of neat. But that's the key thing you have to understand. And some people may want to do that. They may want to check their temperature minimum through a period to see what their sleep phase is. And that would be the minimum, the middle of their sleep phase. And if they needed 8 hours per night, which takes a while to figure that out, then you know that it's 4 hours on either side of that time. That's their sleep phase.
Is that the only way to figure it out?
Well, there's other ways, but that would be the easiest clinically to do for you guys, because you can't get really elaborate and stuff. But there are many different things that we'll talk about in the questions at the end to answer that question, right? Because that's important. So understanding those things, that's sort of the foundation. Understand that sleep and wake are connected. Sleep debt's very important, and it's a function of being awake too long. And that you have a circadian rhythm that's endogenous to you. If you're a night owl and there's other night owls in your family, it's genetic. That's it. It's in your genes. And we know that there's a genetic predisposition to a delayed sleep phase or an advanced sleep phase. That's well described. There are 4 genes that control the circadian rhythm that have been identified. This now is sleep architecture, and this is the ultradian process. And what you want to sort of understand here is that these are the stages of sleep, 1, 2, 3, and 4. Light sleep, 1 and 2. Deep, slow wave sleep, 3 and 4. What hormone is secreted during stages 3 and 4? Sorry? Growth hormone. Okay, so this is, you guys hear this all the time, eh? All right? So stages 3 and 4, and in your athletes that are in the peak of their performing years in their 20s, let's say, they're going to have the most slow wave sleep up to their 20s, and from that point on it will decline into adult life and older age. So the maximum amount of slow wave sleep you will get endogenously will be up to your 20s, and then it starts to taper off. This is important. And there aren't any ways to manipulate getting more slow wave sleep, because that's a constant question that I get. If you're well rested, well slept, you're going to get a maximum, and that's it. That's all you get. Okay. When you are sleep deprived, the first thing you will recover is slow wave sleep. So your athletes, who are chronically sleep deprived, most of them, are always going to get extra slow wave sleep because they're sleep deprived. So as soon as they go into a nap, they're going to go straight into slow wave sleep. How many of you guys nap? How many of you wake up feeling like a bag of dirt? Okay, that's because you're waking up in slow wave sleep, and usually you've let your nap go too long. That's very important. So efficient napping is critical. Okay? So the last then, of course, is REM sleep, which is in the red, and that's dream sleep. Okay? So if you go across the night over 8 hours, what you see is that every 60 to 90 minutes, this cycle repeats itself. And you notice that REM sleep becomes more dense as we approach morning. So those nice dreams you wake up out of on a Saturday morning, that's here. And slow wave sleep is at its maximum in the first third of the night. This is very important. For those of you who routinely wake up 2 to 3 hours after you go to sleep, that's because you're transitioning from deep slow wave sleep to light sleep. And you'll wake up. Everybody has an arousal every 60 to 90 minutes. The question is, do you wake up? And then the next question is, do you stay up? So how many of you treat athletes who complain of insomnia? Anybody? Don't know. How many of you ask the question about sleep? So this is important because a lot more of your athletes than you think have trouble with insomnia. We were shocked when we surveyed 82 athletes and 9 coaches on the team of how bad their sleep was, because they don't know. They don't care. They just whatever. But it's a big problem in athletes for a host of reasons. So these cycles are called ultradian cycles, and they're critical to understanding why people will have fragmented sleep through the night, or why they will wake up and not be able to get back to sleep. Okay? So at the end of the day, all of these processes combine into this map of what it takes to sleep. You have sleep debt, which accumulates over the day. And when you wake up, you're fully recovered. As the day progresses, as our day progresses, you are becoming sleep deprived, which is why you fall asleep at night if you're not an insomniac. Okay? And then you recover your sleep debt through the night, and then the process starts over again. In addition to that, you have circadian alerting signals. So how many of you have stayed up all night, felt absolutely horrid at around 6, and then all of a sudden woke up at 8 in the morning, right? That's your circadian factors kicking in, and they're going against your sleep debt factors. So that's fine 1 or 2 nights in a row or 1 night a week for a little while. But if you're an intern or a resident on 1 and 3 call, and every 3rd or 4th night you're up 24 hours a day, that accumulates into chronic sleep deprivation. Or a shift worker, a rotating shift worker. Okay? So at the end of the day, you get an alertness cycle, which then tells you your highest peak of alertness is at this point in the day. This point in the day, you have a drop-off post-lunch, and then, of course, you drop off into the night. And that's normal. So the circadian cycle includes a low point in the day that has nothing to do with lunch. That's the time you want people napping. You want to take advantage of that circadian low and get them a 30-minute nap if they're well rested, or a longer nap if they're chronically sleep deprived. That's key. Okay? And so what we did at the Oval was we built a napping room for the athletes. And they used that to sleep during the day. They'd never done that, never thought of that before. So during training, because they had 2 cycles of training, morning and afternoon, they would nap. Okay, so that's important. Day rest for these athletes. So you guys are training professionals, different people who have no opportunity to rest during the day. They're working people. They're athletes who have jobs. It's going to be hard. They're doing too much. They're going to run out of gas somewhere along the road. So when we look at sleep metabolism and training, what you got to understand is that, having read this chapter again last night in one of the better textbooks on this subject in athletes, we don't know what we're talking about. We don't have a clue what we're talking about. Partly because the studies that have been done haven't been done in a way to give us an answer that we can give to you as clinicians that you can use in the field. So a lot of what you hear is hocus pocus. Sorry, but it is. So it's important to understand the limits of the data that we have today. And most of the people who do this work and understand this work and have done the studies are well acquainted with the limitations of all this supplementation stuff that's being purported to work. We just don't know. And it's a very complex thing to study. But what we do know is about the groups of hormones that are involved in overtraining and training stress and non-training stressors and what they do. We have some limited understanding of what the role of GH is, growth hormone is, what the role of cortisol is, thyroid, prolactin and whatnot, and then all luteinizing hormones and whatnot, the gonadal hormones. So we understand what they do in normals, and we are getting to understand what they do in athletes, but it is limited, and we don't have really strong evidence to say, do this and you will get that. It just isn't there in the literature. The neuroendocrinology of overtraining involves the HPA axis, or the hypothalamic pituitary axis, and the hypothalamic adrenal axis, and the hypothalamic pituitary gonadal axis. So those are the two that you'll see in overtraining syndrome. You'll see the symptoms of those two axes being overworked and what the end results are. And I think you hear a lot about adrenal overload and adrenal stress, and that is the HPA axis being stressed, usually on two major fronts. One is overtraining, okay, so intensity, frequency, and volume. And then also, these athletes are emotionally very stressed, and you guys see that. This, the hypothalamic pituitary gonadal axis is affected primarily in women and is seen in menstrual irregularities, and that's usually in women who enter into training with an irregular menstrual cycle. It's not been shown that women who enter into heavy training with regular cycles have any difficulty. So that's important as well. So not all women are going to have trouble. What I'm showing you here, and what's important here, is to understand the relationship of sleep to the secretion of the hormones. So you get a little bit more. And all you want to understand, very simply, is that this is sleep at night, this is awake at night, and this is sleep during the day. And what you can see with growth hormone is it's sleep related. It is not circadian related. Okay? Growth hormone secretion is a function of slow wave sleep. And that's well understood. It's not a circadian driven process, because you'll hear that and it's wrong. Plasma cortisol, however, always peaks in the morning in normals, regardless of whether you sleep deprive them or not. So at night, it's low, which is what it should be, even if they're awake. So that's a circadian process. It's driven by the timing of the clock. And cortisol is something that you guys see a lot of. They do a lot of these profiles and whatnot, and they try and assess where athletes are at based on where their cortisol is. But we know that the testosterone-cortisol ratio doesn't tell us anything about overtraining. We know that. There's very little evidence to say that that ratio tells us much. Okay? Prolactin, again, peaks at similar times. Okay? But if you keep a person awake at night, you'll get this low that you expect to see. Okay? And then TSH, again, thyroid stimulating hormone. If we look at, again, nocturnal sleep, you have a peak, so that's normal. If you keep someone awake at night, look what happens. So there's something about keeping a person awake, a shift worker, where they have an overshoot of thyroid. So that's abnormal. Okay? And then if you sleep during the day, you don't get the normal elevation in thyroid. Okay, so it's a circadian-driven process, and partly sleep. So if we look at human performance, we stratify it according to mood, cognition, memory, physical functioning. So these are the things that we look at, and mood is the first thing to go when you sleep deprive someone. People get bitchy, bottom line, okay? And they don't get depressed till down the road. Cognition is very carefully evaluated. The work that I do at the police is in attention and ability to shoot a gun, drive a car fast when you're really tired and not screw up. That's the bottom line. So all of the major industrial accidents that have occurred primarily in the middle of the night at the low of the circadian rhythm, which is when we're most impaired. And impairment, according to sleep deprivation, impairment has been linked to being over the legal limit of alcohol. So this is important because if you keep a person up over 17 hours straight, once you hit 17 to 23 hours, the decrement is at 0.05% alcohol, and then as you go past 23 hours, you get 0.1% blood alcohol concentration. So the equivalent. So that's important because we now have something we can really rely on as a measure. Memory is a controversial issue when it comes to sleep. We don't actually know if sleep has anything to do with memory consolidation, but people will tell you when they start sleeping better, their memory improves. Physical functioning, we do know. You keep sleep depriving people, and their ability to recover will be limited. Their ability to perform will be sustained to a certain level, actually, if they're young and fit. They can put up with a lot of stress to a point. And then what you're going to see is poor recovery. Okay? So this is the book, one of the sort of foremost books in this. This book is out there, and I highly recommend it for anyone who wants to learn. It's a very slow, miserable read, but it is the text. Okay? Now, my interest is that sleep has become such an issue in elite athletes that this year the clinics in sports medicine devoted an entire issue to sports chronobiology. This is an excellent summary of the relationship of sleep to athletes and performance, and it goes through all the aspects that have been looked at, and at the end of the day, not much research has been done in this area, so we're doing more and more. And I'm just tabulating. I just finished writing the abstract this morning for a submission on our travel management and jet lag program that we used for the team last year and studied the outcome over one season. So this is becoming a deal that's going to be used in elite athletes in the future to try and help them cope better with sleep stress. So before I go on to the training side of things, do you have any questions? Do you want to ask your questions now? Sure. Come up to the microphone so that we can hear them. I'm going to sit down because I need a break.
How can you figure out the low point during the day when a person should be napping?
Okay, so what we're going to do as we go along, I'm going to show you 3 cases. And what I would suggest is you use sleep logs. And I've given you a sleep log that you can take off the internet. Ken has all this stuff on the website, so when you leave, you can download the presentation, and the last page of the presentation is a sleep log. And just take it, and I'll show you how we use them to determine clinically what they're doing now and then how to get them into their normal sleep pattern. So the most important thing is to get information from the sleep log, start to look at where they trend and what the patterns are, and I'll show you those patterns. And then determine simply, are you a night owl or are you a lark? Does the person wake up and feel refreshed in the morning, or do they wake up and get themselves going with 13 cups of coffee and a liter of Coke and going to the gym? The athlete you're going to see in this story is someone who, when you talk to her and took a good history, she got out of bed and she went straight to the gym. Why? What was she doing at the gym? Trying to wake up. She was using training to wake up. That's not good. That's a drug. So you need to learn that. You need to know who your athletes are that use exercise to stimulate themselves, and the athletes who wake up, feel refreshed, wander over to the gym and start training. There's a difference. That's the key factor. Your anchor for the sleep period is always the morning.
What about the process for a new mother? I have a 3.5-month-old right now.
Okay.
Obviously, I'm up a lot at night, and with training, just the whole process. I guess you can comment on that.
So the question is, what's the process for a new mother? Yeah, don't train. It's not good for you. It's not good for you. So the point is you have to adjust. You have to really adjust because you're not getting enough sleep. And there will be a negative return at some point unless you're you got a huge tank of gas. Because you know when you're running out of gas. You know what and my first question to people like you is, how do you feel after your training? How do you feel?
I feel not bad.
Good.
You're saying
That's it. Right.
health-wise, it's probably not good.
No, it's terrible for you. So you have to make decisions because with the way society is now, we don't get enough sleep. And you're seeing a problem. Obesity is linked to inadequate sleep. That's well researched. So if we have athletes pushing themselves beyond with not getting adequate sleep, and I see tons of moms who are national team members, and it's hard on them. And they come in because they're having a rough time coping with the constant awakening at night, waking up early to train, and then, being tired. So it's always recovering sleep debt. That's the bottom line. So there's no strategy. There's no process. It's insanity, because it's too much. So that the only answer for people in those situations, shift workers who, they come off night shift and they go train. Like, that's ridiculous. They need to sleep. So I have to deal with my cops who are training at 2 o'clock in the morning. That's just not good for you. But they don't know that. So it's really important. And when people are overtraining, they don't feel it. They feel fine until they start to really get run down. And that takes a long time. That's why we need to look at the process over time in these athletes. Because you could have predicted when they were 17 what was going to happen. And we're seeing them at 27. And it's people like mums who are on the Olympic team having babies in the middle of their peak of their competing lifespan and then getting more and more disrupted. So it's hard on them. Some get through it, no problem. Others suffer. So it just depends on the individual. So you might be quite resilient, but you got to be careful. Recover your sleep is the bottom line.
Do you feel that's a prime reason for chronic fatigue for these police that work out at 2 in the morning?
Okay, I'm not sure. I'm not sure what your question is.
Well, chronic fatigue, people are always tired.
You mean chronic fatigue syndrome? Okay, so the question is, do I feel that this is an issue in chronic fatigue syndrome? And I would argue maybe, maybe not. I don't know a lot about chronic fatigue syndrome because I don't see those patients. I deal with, overtraining and athletes and high performance people who don't have that label or name. They're not dysfunctional in the chronic fatigue way. They're still working, they're still training, etc. Okay? Yep.
How would you supplement melatonin?
Okay, well, I wouldn't. The question is, how would you supplement melatonin? And my answer would be, don't. There's no point. The key thing is that there's no value to supplementing it physiologically whatsoever. In a young person, if they're sleeping properly, they're going to have a normal secretion of melatonin. There's no reason to supplement it. And light therapy, in fact, regulates melatonin secretion. So it's a natural way without supplementation to get the end result. So the only reason we use melatonin is in clear cases where there's shift work, phase delay, jet lag, where we know it's been studied and it works. But then you have to know the individual's timing for the dosing. And so I don't see any point in supplementing melatonin at all.
Any value to certain hours of sleep being more restorative, like example, 7 to 9 being very restorative for the adrenal glands?
Okay, so the question is there any relationship between the amount of sleep and the restoration of the neuroendocrine function? And the answer would be the first thing you need to know is how much the individual needs, because that makes no sense at all. The most important thing is to know what the individual needs for a sleep time. And it will take you 28 days of free running, allowing them to sleep when they want to determine their actual sleep need. 28 days, 14 to 28 days. And we don't get that because we have to wake up. So the point is, if people wake up spontaneously in the morning without an alarm clock, that's their time to wake up. If they need an alarm clock, they need to sleep longer. Okay, these are simple ways of assessing this. Okay, the relationship to recovery is irrelevant. What's relevant is what is the person's sleep need and what is their sleep phase. So if I take that 8-hour-a-night person and make them go to bed at 9 and they're a night owl, yeah, we're going to screw them right up. And it's actually cortisol is going to be all whacked out. Okay? So that's a problem. So it's not that 9 hours is better for your adrenals or cortisol or whatever. It's the individual sleep need and their sleep period that you need to figure out. This is quite contrary to what you're hearing. I know. Yep.
What about oversleeping?
Well, the thing is, you can oversleep, But most of the people you're dealing with are sleep deprived. So oversleeping is not really an issue. Chronically fatigued people will oversleep because they just have no energy. But in a well-rested individual, they'll just sleep as much as they need and wake up and be on their way. Okay? Sorry. Yep.
I train a lot of very stressed executives.
Yeah.
In their 40s and 50s.
Yeah.
Typically works. So early to bed, early to rise. Not just demanding the job, but performance is good in the gym relative to what I was expecting. But many complain that 2 in the morning they'll wake up and have a busy brain.
Right.
They're going through their to-do list now. Either their ergogenic ones or methods of reintroducing sleep patterns.
So the question is the stressed out executive, bottom line. How many of you deal with them? I feel sorry for you because I do. And those are my patients. So you end up sending them to me. And I see tons of them from the oil patch downtown. And the first thing that's very important to understand, first of all, is that they're not larks. They force themselves to wake up early to get to work. That's important to make that distinction. So you need to find out who the night owls are who are forcing themselves to wake up too early. That's very important because they're going to run out of gas. Now, you're seeing them in an age range probably 30 to 40?
40s and 50s.
Okay, so are they running out of gas or pretty healthy? Fit, doing their thing, happy?
Fit doing their thing, their complaint is, they wake up 2 in the morning and immediately start to do their do list and they want to quiet their brain then.
So the key thing you have to understand is that this group of people are all suffering from psychophysiological insomnia, and it's ubiquitous in that group of people. They have insomnia, and the question is, what do you do when they wake up at 2 in the morning and they've got the busy brain? The fact is that these guys are so busy and so cranked, and they need so much work to calm down, there's no way. There's nothing. They need to see a sleep doctor badly, because these are people that family doctors come to me and ask, what am I going to do with them? And it's very difficult to treat them. And the
Name for the Toronto area?
Yeah, I do. I got a lot of names, actually, so that's not a problem. I'll do that at the end. Okay, so let's move on to the training side of things. You guys know this stuff, but adaptive training, of course, involves overreaching. What you want to do is stress the athlete, let them rest, and then they recover at a higher level, and then this is normal training in a professional setting. And so this would be adaptive, where they train hard, they go down, they recover, they train hard, but they're always on the upswing. They're always moving ahead. And you have many indicators, clinical and biometric, that you can use to measure their slow improvement. But this is maladaptive training, where their performance starts to decline over time. And you see that in their recovery, because actually performance can be sustained in an overtrained state for a long time. So it's like the mums. They can go hard, but one day all of a sudden they're going to hit this limit. And what I see with the Olympic athletes is they'll usually tell you over a period of 3 years they had 3 illnesses that resulted in a 1 to 2 month layoff or injury, and then they come back, and then they overtrain too soon, or they go back too soon, and it's that cycle, and then they do this slow decline. And then the one that I'm going to show you today was fearful of going back to training. And she's on the Olympic swimming team, and she's scared because she's afraid of getting so fatigued. She hated the way she felt. So the overtraining syndrome has been characterized into a sympathetic type and a parasympathetic type. They don't necessarily go along a spectrum. They could be completely independent. But what you see in the sympathetic type is overdrive. And bottom line is they're insomniac, irritable, okay? They have impaired performance, the supercompensation is impaired, and they have a very high resting heart rate. So does anybody use the Rusko score here? No? Okay. So the Rusko score is used by these guys to measure their heart rate response in the morning and to see if they're getting fit. And their blood pressure is elevated as well. And they have a slow recovery after exercise. So these are things you see all the time. And that would be a sympathetic type. The parasympathetic type, obviously from my point, it's not that they're not sleep disturbed. It's that they sleep too much now. And you'll see them go through a cycle of being overslept, and then they develop insomnia. I see that a lot. Like they get so fatigued that they're sleeping all the time, and then all of a sudden they become sympathetic and they develop insomnia. And we believe there's a major nutritional factor there through the process of overtraining, where they're depleting the substrates required for the neurotransmitters to sleep and have normal function. Okay? So all of these other factors are affected here in the parasympathetic type. These tend to be very blunted individuals, very fatigued, can't respond, tired all the time, depressed. So the thing is that we want to do studies of incidents which have to be done over time to determine what the natural history of overtraining is, and that hasn't been done. Highly motivated athletes who are excessively busy tend to overtrain. So there is a bit of a profile there that those people who tend to keep going when they're feeling that they can't, and there is a profile, those executives are the ones who end up overtrained because they train too much. And in overtraining research and literature, the bottom line is undertraining is better than overtraining. That's the bottom line. That's the only thing you can hang your hat on. If you have a choice, train less, which is hard to get an athlete to do. Prevention is achieved by knowing much more than is currently known about overtraining because we only deal with when it happens. So I'm going to give you the athletes here. So I have a 17-year-old high school athlete. She's on the provincial hockey team, and she's a goalie. And she was recruited to U of T on a hockey scholarship. And she presents with insomnia and situational anxiety. So she was sent to me by the psychologist who was treating her for anxiety related to exams. And then he found out that she had a lot of trouble sleeping. So she had a 2-year history of insomnia associated with stress. She has a delay in her sleep phase due to evening training. So she is a kid who is a natural night owl, but reinforced her night owl tendencies because she's a hockey player by training at night. Because it felt good. She was most awake at night, so that reinforced her delayed sleep phase, and she had to wake up in the morning. Situational anxiety with exams and with her hockey, in spite of the fact that she got a hockey scholarship, so she was pretty darn good. Her bedtime was 11 p.m., and it took her over 1 hour to fall asleep, at best. She wakes and becomes anxious, watches the clock, and stays in bed. So these are your guys. In the middle of the night, they're doing all the wrong things. They wake up, they look at the clock, they're freaking out. Right? Then they go to the computer, start doing email. Bad. Okay? Terrible. You tell these guys, get out of bed, go to a room, and watch the fishing channel. Unless they like fishing. Just relax. I'm starting to send them all to meditation classes because they're just cranked, these guys. Okay? Because you've got to teach, what it is the brain wants to sleep, but the mind won't let it. They just get cranked, eh? And if you just relax the mind, they just go right back to sleep. Don't look at the clock. And how many of you guys look at the clock in the middle of the night? Don't lie to me. I know. There you go. Stop it. What are you supposed to do at night? Sleep. Okay? She gets out of bed at 8:30 a.m. and feels well in the morning, but gets tired as the day progresses. So this is Shannon. She has situational anxiety, which is her psychiatric history. Her medications are Ativan or lorazepam, which she takes PRN, which is Valium, in a 17-year-old, okay? And Imovane, which is a similar drug as Valium for sleep, okay, on occasion. She has very poor insight and motivation. She's grumpy with me, and her mom's there, and her mom's whacking her finger at her and everything, and you know this ain't going to go well, right? It's not going to go well. This is just before exams, grade 12. Then she's got the summer, and she's going to U of T, okay? So we give her a sleep program and some advice because this kid doesn't give a damn about what I think. Okay, so let's look at her sleep logs when she returns. Like, this is horrid. Okay, she goes to bed, 1 o'clock, 12:30, somewhere 12, 11:30, 12. This is ridiculous. Like, pick a time. Okay, she's getting a terminal awakening. Okay, and it just isn't going very well. Right, so this is a very erratic sleep schedule. She had a nap over here. She's got all this at 9 o'clock. So you see her anchor in the morning is terrible. She's anywhere from 6 to 9. This is not good. This is after I saw her and gave her a sleep program. So she wasn't keen on behaving. Okay, so this is all the weeks that she does. This is the sleep log that I recommend using because it's simple. Okay, don't make it too complicated for them. Okay, and I mean, it just keeps getting worse and worse. But look, she recovers a whole ton of sleep here. I'll go back here. This is the week prior. Look at just really restricted sleep. 12 to 7 hours. Now, remember, teenagers need 10 hours of sleep a night, eh? This is terrible. So as soon as we sleep deprive her, she catches up and ate. You see that? So this is how you can tell. And you can show them and go, hey, smarten up. Okay? Just all over the map here. All over. Look at this. This is terrible. Look at that. You're like, what are you doing? And you want me to help you? Okay. So very poor progress. And then she went off to university, right? And she roomed with a bunch of kids, and it was terrible. She couldn't sleep. She had insomnia. You know, it was just terrible. So not only do we have a problem with her behaving, she couldn't follow the program. She had a terrible environment for sleep. So she then got a private room. Her sleep restriction and light therapy and training schedule adjustment. So then I would see her at Christmas when she returned, and I said, look, you know, you have to change your environment. They got her a private room. We have to do this. But she had school to go through and hockey in the winter. So it was a long year. So when she came back in the summer, she said, okay, I've had it, man. I can't take this. And I said, okay, you going to listen? And she said, fine. So the biggest issue for her was, I get up at 6 and I go to the gym. That's what I do. I've always done that. I said, no, you're a night owl. You have to get up at 9. Can you imagine? She freaked out. She was not happy. But I said, you want help or no? Because I'm a busy guy. I got other athletes. See you later. So she said, okay. So we needed a total sleep time of at least 8 to 9 hours because she still needs 10. Okay? And off she went with 6 weeks of stable sleep and a stable training schedule. And you'll see the result here. So we used light therapy with her. So those little lights. So she'd wake up every morning, have her breakfast. She had to eat breakfast. Okay? So she had the light and she ate her breakfast. She waited a little bit. She went off to the gym and she said, whoa, you know, this is great. Boy, I feel way better, you know. And I didn't make this up. This is real. And we incorporated a nap in and she really stuck to the routine. And you'll see the result right here.
If you have a teenager at home who won't get out of bed in the morning but won't get out of bed at night either, or won't go to bed at night either, that is, you're not alone.
Many teenagers are suffering from a serious lack of sleep, and when it gets really bad, it can affect their school performance. Karen Owen has more in tonight's Medical Watch.
18-year-old Shannon Miller is heading off to hockey practice this morning, refreshed and well-rested, but it wasn't always that way.
Again, how much sleep were you getting before treatment?
Probably like 4 hours a night, 4 or 5 hours.
It wasn't enough. Shannon couldn't reach her potential on the ice or during class.
I was drinking pop like it was going out of Stat Pop and coffee, like to get through class.
Shannon's sleep problem isn't an isolated case. There are a lot of teenagers not getting enough sleep. But just like adults, some teenagers cope better than others.
For the teenagers who are not coping, the answer may be readjusting their internal body clock or circadian rhythm. In the teen years, this body clock gets reset, making teenagers want to fall asleep later and get up later.
About 20% of teenagers will experience this delay in the sleep phase where it's significant.
What makes it worse is that teenagers need about 10 hours of sleep a night. Shannon Miller started using light therapy every morning to treat her delayed sleep phase syndrome.
And it just moves their sleep phase backwards.
So they can start actually falling asleep earlier in the night.
Yes.
Shannon now aims for 7 to 9 hours of sleep every night, and she sleeps in a little on the weekends.
Really, it's just math. Basically, they need 70 hours of sleep per week.
Shannon says getting enough sleep has made an impact at school and on the ice.
I've made more gains this summer than I ever have.
Bottom line for many teenagers, they need to do less, like turn off the computer earlier, so they can sleep more. Karen Owen.
So you get the point. And she's a great example, and you guys see these people all the time. And I understand that a lot of you deal with athletes, but my point is, if you go back to when they're 18 or 17 and start to ask questions, you might find out why you're having problems now with them, or you might detect these executives becoming overtrained at some point down the road. So this is why you have to look at overtraining not when the event occurs or over a period of time in the year that it occurs. You have to look way back, Because if these people have been running out of gas over 10 years, it's going to make your job way harder. And there ain't no supplement that's going to fix them. Trust me. These people are wiped. And they need to rest. And what I'm finding is, and I didn't realize this, is even at the Olympic level, their nutritional advice is not being dealt with during the time that they're overtrained and being told take 3 months off. No one's giving them any advice on what to do, which is the critical time to be advising them with nutritional advice and whatnot, okay? And it depends on whether they're strength training, strength sport, or endurance, because there are differences. So the bottom line here in a case like Shannon's is that she had situational anxiety and conditioned insomnia, which is what your executives have. They have a state of conditioned insomnia, and they're waking up at 2 for the reasons I explained before, but their mind gets going, can't get back to sleep. So that's the key. She also had a delayed sleep phase. Now that's a physiological thing she has no control over. So we have to fix that, stabilize her sleep with light, and then get her on. And there's no point in using melatonin in those cases because melatonin will only work for 3 to 5 nights at a time and then it stops. So you want something that stabilizes the sleep period consistently. And light is what does that. She had an environmental sleep disorder. She got a room at a college with 4 other roommates who didn't give a crap about her sleep. Okay? And she had early overtraining. She would have gone, but you could see how much pop she was drinking? These guys are drinking like, anybody who's drinking 3 liters of Coke a day, ding, 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 there's a problem, eh? So if you've got people consuming lots of caffeine, there's a problem here. It ain't because they like Coke. They're using the drug. So the management is, the first and foremost, is psychology. This kid needs a psychologist to help her with her anxiety. She needs to get the environment sorted out, adjust the sleep phase, and training schedules, get more sleep, and then the light therapy. So that's what we did to manage her. And she's doing very well now. Case 2 is a male, 29-year-old male national team speed skater and university student who was sent to me by the team physician with initial insomnia. But not only did he have initial insomnia, difficulty falling asleep at the beginning of the night since junior high, and he clearly was a night owl since junior high. And this is when you can ask the question to the mom or whatever, is this the kid you had trouble putting to sleep at night? And they go, oh yeah. And was this the kid you had trouble getting to school in the morning? Oh yeah, they're a night owl. Okay, so that's a simple question. Okay? Because the kids that went to bed and off they went to sleep at night, they're not so bad. But there's those kids, when they were little even, had trouble going to sleep, they're night owls. And it always comes on in grade 7. Somewhere in the early junior high years, they'll start to shift their sleep phase with puberty. Okay, so some could be good sleepers and then become delayed phase and then go right back to being normal after high school, they're fine. Or others will just keep reinforcing the delayed phase. Those are your musicians and artists who love staying up late at night. Okay? So he was using melatonin and a regular sleep schedule, which did help him. He was actually able to correct his sleep schedule on his own, and he found it beneficial. And that's pretty good, because this is a guy who had both night owl sleeping habits and clearly winter depression. He would always in the winter season become quite depressed. And the reason he was sent to me was that he got very depressed following one set of Olympics. So Prozac was used to stabilize his mood. He went off to a monastery to learn. So you can send these guys to a monastery in California, all right? And he found that very helpful. And I'll tell you, I'm becoming a big advocate of meditation and yoga because it seems to work. He was healthy otherwise, totally healthy guy. And he was on Prozac daily and melatonin he used occasionally when I saw him. Okay? We gave him a sleep program which you can't see here, but you will be able to read. And just to give you an idea, this is a template right out of my electronic chart for the patient. They come in and we make up their sleep program. And basically the bedtime, wake time is there, weekdays, weekends. And we set it at 11 every night and a wake up of 7 on weekdays, you had to, and 9 on weekends. So again, we're using a rigid schedule with a prescription, which you can do. I mean, that's simple, okay, once you figure things out. Basic sleep hygiene rules, you know, don't watch the clock, don't drink coffee after 4 p.m., don't smoke, which your guys probably don't do, and alcohol, all of these things that affect sleep. Very simple advice, it's all in there. And then lifestyle regulation. And usually what I'll be saying to these guys is about eating in the morning. I'll be telling them, you got to eat in the morning and you got to have protein in the morning. You got to wake your brain up. So you need protein in the morning. It's very important. So they get a sleep program, and then we start to look at their sleep schedule. And you can see he's quite erratic. The red numbers are his Rusko score, which is pulse. He takes his pulse when he's lying in bed, and then he stands up, and then every minute he takes his pulse for 15 seconds. And what should happen is that it will be low lying, it will be high in the first reading, and then it should level out if you're normal. And when I saw him, he was in a better state. So these numbers are not too bad. Okay? And you can see that 57 lying, 90 when he stands, and then it starts to level out. Okay? And that's a normal Rusko. Okay? A little bit high, but not bad. Okay? Again, still not stable, definitely not getting enough sleep, but you can see when he gets a lot of sleep, he's way better than when he doesn't get enough sleep. And a broken sleep, 6s, 4s. And it accumulates. It's not night to night. It's over a week that it'll start to accumulate in these guys because they're pretty tough. So you need sleep logs to look at it over time. Okay? Very erratic. He just can't maintain a schedule. Classic night owl. Just classic. But when he forces himself to stay in a schedule, which is hard for him, he feels way better. And he'll tell you that. Again, like this is very erratic, eh? Not enough sleep. He feels terrible here. And he's accumulating his sleep debt, so now he's getting down to a 4. Okay? Same thing. Just not consistent at all. Look at this. This is terrible. Just back to this one, you know, he says he slept well. So it's not that he's not sleeping well. He's just not getting enough sleep. Okay? And as soon as he regulates his sleep pattern, he becomes much more consistent. Not great, but consistent. But he's accumulated a ton of sleep debt prior to this, so it's going to take him a while to recover. And he's starting to get a little bit better. And his numbers are starting to go up here. So he's feeling better. So you can see he was very meticulous with sleep logs because he wanted to get better. But the bottom line with him is he was living in a basement apartment with mold. So there was an environmental problem. As soon as he left the apartment, he felt like $1 million. So this had nothing to do with his sleep. But that would affect his nighttime sleep. Sleeping congested with an environmental allergy. Okay? Without light therapy, he cannot regulate his sleep schedule. So he tries. It's hard. But with light, no sweat. He uses the light every day. It just regulates his circadian rhythm. No problem. He maintains a regular routine and finds that his training is way more productive. Yeah?
What type of lights do you use for light therapy?
Okay, so the question is what type of light for the light therapy? The bottom line is that the light has to have certain specifications. First of all, 10,000 lux. Write that down. Minimum, okay? The other thing is the wavelength of the light should be in a wavelength range of about 450 to 550 nanometers, which is blue light. Okay. So the light that they sell out there is probably on the market today. Again, I haven't been sponsored. Okay. The one that really is the one that focuses in on those domains. It's never been studied to say that it's better than the other lights, but it's really compact. So I tend to use that light. But I offer people a wide range of lights. You know, there's ones in Quebec but they're huge. They're not easy to travel with. Okay? Now, there are knockoffs of that light that you have to watch for that don't have the 10,000 lux and the right wavelength. So you have to look at those two factors. That's what you want. Okay? So again, as soon as he stops light, I love testing this out. I tell him, okay, well, we don't know if the light really worked because I'm just egging them on. Stop it for a week. And as soon as they stop it, they feel terrible. Then you know it's working. So that's a great way to test the light. It proves to the athlete it's working, that it helps them, and then they're committed to using it because it's all about motivation, keeping these people going. Okay? But his total sleep time is still less than 8 hours a night. So he still is chronically sleep deprived and complaining of those symptoms. Yep.
How long do you use the light for?
30 minutes in the morning. How long do you use the light for was the question. And it's for stabilizing the circadian rhythm. 30 minutes is sufficient. You can go up to an hour, but a lot of people don't have that time.
In the morning?
Yeah. Yes. Very important. Okay. So the problem list here is he had delayed sleep phase, depression, and seasonal affective disorder. So mood was a big issue, environmental issues, and insufficient sleep syndrome. So the management is to stabilize the mood with light and Prozac. So we're stabilizing his depression with a drug and his circadian and seasonal variation with light. And then we address the environment. He had to move and then stabilize the sleep phase. But he still has to increase his total sleep time. And it's hard to get night owls to get enough sleep. They're too busy. They like to be up and they don't want to miss the party. Okay, my last case here is a national team swimmer, an Olympian. She's a 9-year veteran, 26 years old, headed into her next and last Olympics, completely overtrained. And the fun thing about this is when I saw her, and I just saw her on Thursday before I came here, so I can tell you how she's done. But the bottom line is that she has had initial insomnia and light sleep, so she is an insomniac since she was a child. Many of your hyper-aroused, keen athletes who train like mad and are busy and they do band and they do this and they do that and blah, 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 very hyper-aroused people, okay? The overachievers are going to be insomniacs, okay? And they're going to describe light sleep. Oh yeah, I sleep, but it's really light, but I don't care. That's not good. Okay. So she didn't have a night owl preference, but she was very anxious and perfectionistic and high-performing individual. So she's generally good recovery. So she was on the team, the one gal that everybody said, wow, can she recover? So she was very adaptive with her training. You could brutalize her and she'd come back. So she had a reputation on the team for being someone who could tolerate heavy training. And so the key thing was that in the spring of 2004, she had a flu-like illness. She generally good recovery from heavy training loads until the spring of 2004. She had a flu-like illness in the fall of 2004 following the Olympics and World Championships. And this just progressed. In November, preparing for nationals, she performed well, but her recovery was slow. So there was this slow progressive decline over a period of about 6 months. And in the spring of 2005, she suffered pneumonia. So that's when you know. When these people get really sick, it's over. Because these are healthy people. So their immune system is shot. And that should be an indication to everyone there's a problem and we need to take it very seriously. But the problem is that the physicians will treat it as pneumonia. We'll treat her pneumonia and she'll recover. But there's a lot more going on in these guys. And their assumption is, okay, I'm better, I'll go back. You don't recover from pneumonia in 6 weeks, trust me. It's important to keep these things in mind or you'll just keep running them down. And so she's been off since the spring of 2005. She was off when she came to see me about 8 weeks ago. She's now deemed recovered biochemically by her endocrinologist. So all the sports physiologists, everyone, all of her biochemical markers are back, and she feels like hell. So even though she's biochemically better, she doesn't feel like she could tolerate the training load that she has to go back into, and she doesn't feel good because she's not sleeping. She has terrible insomnia. And the problem is that right around the time that she got sick or this began, she found a boyfriend and started sleeping with him. And she couldn't sleep with someone else. That goes right back to there. You could have predicted that. If you knew that this kid was a light sleeper and you did a profile of what her sleep was like as a young athlete, as soon as she found a boyfriend and started sleeping with him in a twin or a queen, forget it. She ain't going to sleep. And that's what happened. And she'd tell me, she said, I know when this happened and I know why. And the poor boyfriend was sitting right there. You know, I'm the reason she won't win gold, right? Anyway, so, you know, I mean, it's simple. And you could go right back to her sleep history and find out this is not a kid who's going to do well with a partner or definitely a partner who snores. So here she is forcing herself to sleep with this guy because, you know, she wants to sleep with the guy. But she ain't sleeping. So then she gets put on a sedative, which she finds helps. But the problem is she's still suffering from the insomnia and non-restorative sleep. She's concerned about returning to the full training schedule, which is now, and she has had 2 leaves of absence from competition in 2000 and 2005. Well, this gives me a good history that this isn't good. So over a period of 5 years, she's had 3 leaves. That's not good. And now we have an ongoing problem. So she got sent. And the bottom line is that she now requires the sedative nightly for sedation. And she has an excessive need for sleep during the day, which is bothering her boyfriend because she won't do anything. She's no fun. Okay? Her current concerns are her fear of fatigue and need for the sedation, so for the drug. These guys don't want to be on drugs, you know, and this drug is allowed for the athletes. She's hypothyroid, but well treated and well controlled. And she's on Synthroid for her thyroid, birth control pill, and then the sedative, and that's all. Okay? She's an otherwise healthy gal, a real sweetheart. So anyways, she has psychophysiological insomnia. She has learned insomnia. Again, like your guys, overstimulation. But hers is an overtraining syndrome of the sympathetic type. Okay? She has inadequate recovery, and she's sedative dependent now. There's no way this kid is going to sleep without drugs at this point. No frickin' way. So she needs drugs. We ain't taking her off the drugs, or we're going to have a real problem, and she won't let go of them either. But she's using them sporadically because she's concerned about it. She's not using them continuously. So the management is to give her a sleep program to stick to and to give her regular nightly sedation. Make her feel good about taking the drug. Just say, take it because we need to get you better. Sort out the issue with her and her boyfriend so she can have a better sleep environment, and then a progressive return to fall training with close monitoring. But the biggest issue that I found out with her is that she got no nutritional advice when she was on, none, zero. Zero. She was just left to her own devices. That's not good. These kids need really good nutritional advice if they're off for overtraining. Okay? Very important. Get a nutritionist involved right away to help them eat well. And usually, in endurance athletes, they are totally protein wasted. It's not like strength training. Strength training, those guys, too much protein. So the wrong athletes are eating too much protein. Okay? These guys deplete their protein, the endurance athletes, incredibly. So they need more. So at the end of the day, so in her case, just so you know, she returned 8 weeks later, taking the drug every night. She feels like $1,000,000. So she sleeps, she's training, she's tolerating the heavy training loads, she's confident that she can go back, and as far as she's concerned, the only thing that helped her wasn't me, the drug. So we have to have a little chat about that, okay? Because I'm concerned. I don't want a 27-year-old gal on drugs. So we have to work towards tapering her off the drug at an appropriate time, not now, because she's getting ready for her Commonwealth Games. So she has to, be ready. So we have a negotiation over that. We're working with the psychologist and the team physiologist, and we just have a plan. But that's important. You don't leave these kids on sedatives, okay? Because she could sleep normally if we work with her. So she's quite pleased. Interestingly, though, she told me, and what she found most interestingly, is that she has lost a tremendous amount of weight. And she said, this isn't because I'm back to training, because when I was training as heavily as this, I was heavier. But she's lost 6 to 10 pounds. That's a lot in a tiny little gal. And so she's concerned that this is bad. Now, what do you think? The reason is she's lost that weight. She's sleeping. So her hypercortisolemia, which is what was keeping her going all those years, is now down, along with her high adrenergic state, which was keeping her going, which is anabolic, okay? It puts on fat, was keeping her going. But of course, she could perform at an incredibly high level because, 7 pounds in an Olympic swimmer isn't a lot, but she said, I'm way better now with 7 pounds off. So you have to understand, there's an effect here. How many of you crave chocolate at the end of the day? Yeah, okay, there's a reason. Same reason that cops eat donuts. Okay? So this is important because this is what was happening with her. Same idea. And you see these people all the time in your practice. Craving high-calorie dense foods late in the day. Of course, you just put it off to training in a kid like this, right? They just need more calories. So we can be more sophisticated at the way we look at these things. So bottom line is ask every patient or client about their sleep. And if they describe poor sleep, ask about amount, quality, and timing. Do a sleep history that goes back to teens and then monitor their rest, sleep, and activity and training cycles to detect and prevent the overtraining syndrome. So those are the sort of simple points. And here's some references for you to find out all about light therapy and everything. And if you talk to the guy over there, they have a great website actually with lots of good information. Okay? And this is the sleep log that you can pull off the net. So that's all I have to say. Thank you very much. You've been very fun and interesting. And I'm happy to take questions. We've got 20 minutes. And I'd like you to come to the microphone, please. Sorry.
Hi. You were talking about naps in the middle of the afternoon, and the fact that for some people they sleep too long during those naps and they wake up feeling really bad. So how long should these naps be, and how do we know?
Okay. So the question is about napping, and here's the bottom line. Get your pens out, guys. Okay. First of all, if they're sleep deprived, they need sleep. Pretty simple, eh? So the problem with napping is that if you put them to sleep, they'll sleep for as long as they need sleep. Don't forget that. If they can do that, let them sleep. Okay? Because they'll wake up spontaneously and they'll feel fine. Okay? So that's rule number one. Because most of the people you're dealing with are sleep deprived. In people who are reasonably well rested, but just short a half hour a day, let's say, or an hour a day on sleep, the way to chronically recover sleep is to have 30-minute naps 12 hours from the midpoint of your sleep cycle. So if you're 11 to 7 person, the midpoint of that 8-hour sleep cycle is 4 plus, so 3:30. Somewhere between 3 and 4 in the afternoon, have a 30-minute nap. Okay? So what you don't want to do in your nap, in your strategic napping, which is what we do with cops and military guys and etc., strategic napping is 30 minutes, max, by the clock.
You asked us to remind you about caffeine.
Right. Okay, so caffeine. So how many people here use caffeine to stay awake? Okay. Let me ask you, why does caffeine keep you awake? Give me your impression. Pardon?
Gives me a buzz.
It gives you a buzz. What's that buzz? Anybody know? Okay, it excites your central nervous system. So we assume that it stimulates an adrenergic response, a beta adrenergic response, so an adrenaline response. Okay, so here's the deal. You heard it from me first, okay? That's not how it works. Caffeine inhibits adenosine. And adenosine is the sleep hormone that's accumulating in all of you right now that will make you fall asleep tonight. So this is a vastly different view of what caffeine does than we used to have, because that's what we used to think 10 years ago. And that's not true, actually. So caffeine mitigates sleepiness by turning down the sleep hormone. So we use it strategically. The U.S. military uses caffeine to keep tank drivers awake to kill people. It works. So with the athletes, it's very important because you can use caffeine strategically to get them awake at an important time. So it might be prior to their event or whatever, and they're allowed to drink caffeine. Okay. Okay. So it's important to use caffeine strategically, I think, and I do that with the athletes. If they have low periods in the day when they have to train or whatever, have a drink of coffee. And you know, Starbucks coffee has 400 milligrams of caffeine. That's a lot. That's a lot. Okay. And so one Starbucks will crank you up. Now, if you're over drinking caffeine, you supersaturate the receptors. Doesn't work. It'll make you tired. So strategic use is very valuable, actually. Okay. But using it before bedtime is just downright dumb. So anyone who tells you, oh no, caffeine doesn't keep me awake, but I can't sleep. And I hear this all the time, right? You know, caffeine and booze and nicotine are terrible for sleep. And I can tell you what each drug does to sleep. The bottom line is they're terrible. So they shouldn't do it. You know, I have patients who come in and have a cigarette in the middle of the night. Like, that's ridiculous. Okay, nicotine is extremely stimulating to the brain.
If you have to stay up, say, an hour later than you normally would, is it best to get up the same time that you normally would during the week, or would you stay in and sleep get the full amount of sleep that you should be getting?
Okay, so obviously it depends on your situation, because I can't say do this or that because you might have to get up. But the bottom line in all of this is recover your sleep debt. So if you have to stay up late and you have to get up, you got to do it, but recover your sleep. And if you can do it in that 24-hour cycle, do it.
You don't have to get up, though.
If you don't have, okay, so, but you got my point, right? Yeah. Okay, but if you don't have to get up, sleeping in and recovering your sleep is fine. Especially in young people with no circadian problems, it's not going to make a difference. And it's most important, always most important. First thing, reduce your sleep debt. First thing, always reduce your sleep debt. Okay?
Another question.
Yeah.
What did you recommend to that swimmer about, she was a light sleeper and she realized that she was getting less sleep when she got a boyfriend, basically. So what did you recommend to her?
Drugs every night.
Apart from that, I mean, in terms of sleep hygiene.
But it worked. So the first and foremost thing is if you didn't use drugs, nothing would have worked. So let's say she said, I'm not using drugs. I'd say, no problem. We have to have a talk because you can't sleep with your boyfriend or you're not going to sleep. And I'm very blunt with these guys. Like I tell them, here's the deal. Because you have to. It's what do you want? Because we can't miraculously make you sleep. You have to understand the brain is a very potent thing. And when you make it alert, it ain't going to be on an alert. It's very difficult. So if there was no drug involved, the first thing would be, look, you're going to have to look at sleeping in another room. So develop a system that works for you as a couple. Second, and she's doing that now that they're moving. That's what she's going to do, okay? Even taking the drug. With the drug, we have to talk about any other disruptors that occur from the partner. So if they're snoring, she's hooped. If this guy snores, she's never going to sleep. So that's important, okay? Biggest one is get a bigger bed. So bigger bed is always helpful, okay? And then the important thing in the room is the dark room, quiet room. And then make sure the partner doesn't have a sleep disorder that's keeping her up, because that can be a big common problem. So does that help? Yeah. Yep.
Is there optimal hours that you would want to strive for to sleep between, like say to get to bed by 9 if that works in your schedule and be up by 6? And also second part, for the caffeine, what's the timing for optimal performance for before a competitive event?
Before an event?
Right.
Okay.
Yeah.
So the question is there an optimal time? And I have to come back again to the thing I said at the beginning. No. It's all about the individual. So you have to find out what's best for the individual. It's going to be in a zone, right? So that I hope that makes it clear that there is no optimum time. We know that humans require 7.5 to 8 hours of sleep a night on average. But there's a range from 6 to 9. So you have to find out where this individual is, and then you have to find out what best timing is for them. So does that answer the question? Okay. As far as caffeine before the events, caffeine has a half-life of 4 to 5 hours, which means that it will be out of your system in 5 times that, which is about 20 hours, okay? So its peak of onset is within sort of 2 hours. So you feel it right away, many people do. But usually what we'll say is close to the timing of the event, within an hour, have a coffee. And that will depend on a lot of factors, but that's one guideline.
I'm thinking of societies that traditionally take a nap. Say you're in the tropics or something like that, and you take a nap around noontime because it's just too hot. When it comes to training and that sort of stuff, if you're in a different environment, a lot of people go away, especially swimmers, to training camps in the south.
Yep.
They go from a very cold place to a very warm place. How does that affect the sleep cycles when you switch like that?
Well, first of all, what will affect the sleep cycle right away is time zone changes. So this gal just came back from Florida. where they spent 2 weeks training.
But if you don't change time zones, you just go north-south.
Okay, so if you go north-south, you're going Calgary to down to California, let's say, then your pure problem is just dealing with the environment. And most of them will tell you that it's way easier to cope in a warmer climate closer to the equator, because the individuals with sleep phase problems have less of a problem in an environment closer to the equator. That's actually the key to seasonal depression. It's distance away from the equator is the main factor. So they actually will report that they feel better, and they cope quite well. So sleep is not a major issue.
So in societies where they actually do take a siesta, okay, do they have less sleep orders than we do because we're further north?
Well, yeah, I can tell you about seasonal depression, which has been studied globally. Yes, they don't have SAD in countries close to the equator. But as you get further away, in Fort McMurray in Alberta, as you get further north, it's horrific. So that for sure. As far as sleep disorders go, remember that in Western cultures, we have sleep disorders for a host of reasons. And in climes, southern climes or climes near the equator, the whole the culture is so different that they don't have sleep disorders for other reasons, but they have other issues, motivational issues. And so it's just a cultural difference. But do we see the incidence of sleep disorders like we do in West? No.
How about in societies like a Japanese society where their work weeks and their school years are much longer?
Huge problems with sleep. Huge. Yeah. They're major contributors to our annual international sleep meeting, the Japanese. Yeah.
If you have a person that seems to be able to sleep when it's light or with the light on, but can't sleep when they go to sleep and it's dark.
So you have an individual who sleeps with the light on, but can't sleep with the light
off. And can
off.
only seem to go to sleep when the light's on.
Okay, and they can't sleep when the light's off?
Well, they can, but it doesn't seem to be quality sleep.
Okay, all right. It's difficult. The first thing that comes to mind is fear of sleep and fear of the sleep environment. And so that's the most common thing I'll see is when, and that's very rare, but I'll see an adult who, because I rarely ask that question, but they'll tell you, oh yeah, after an hour interview, oh yeah, I always sleep with the light on. I go, what? So usually that's because as a child, there was huge fear around sleep in the bedroom. So abusive homes, those kinds of things. So that's what comes to mind quickly, but that may not be the case in this person's situation. But it's rare for people to want to sleep with the light on. People sleep with the bloody TV on all the time, and that's just terrible. That's terrible. Thank you very much.